point of care ultrasound technology and all that stuff. All right, that's where it comes from. All right. Medicine, science, uncertainty, arts, probability. All right, and this we kind of sort of use that philosophy and that principle. So where are we going to go? Okay, this picture. What do you guys think about what's going on here? What? Car wreck? What?
Too many people.
Too many people. Okay, but what?
Ambulance looks stuck.
Yeah, ambulance looks stuck. But how is ultrasound and all that stuff going to factor in and play with us? Okay, it has a huge piece, and specifically the second lecture that we'll talk about and you guys will play with, this is where ultrasound, this is what the original purpose of ultrasound was, okay, was because of for trauma. Okay. Is it difficult? Yes, okay, but from there we'll play with and you'll see, and again, the technology is fairly old, okay. The knowledge for you guys is going to be like, oh my God, but you will by the end of today get through and have that piece like going, oh yeah, I do see what Doc is talking about, okay? And we have a whole bunch of different places and all that stuff, okay? So what is POCUS? Okay. Physiologic study, okay? On-spot clinical decision tools, okay? Meaning real world, real time. Someone's in cardiac arrest, you put the probe on, there's no heart activity, guess what? They're dead, okay? You're not getting them back, okay? There's new literature that shows that we have some patients that are in what they call occult ventricular fibrillation, okay? They look like they're in asystole on the monitor, you put the probe on, and the heart is quivering. So guess what? Okay? They're not quite dead yet, which means that you can do things. So it gives you a lot of real world, real time experience and all that stuff. Clinical exam, unique, expanding, and it's safe, okay? It's repeatable. You can put it on over and over and over again, okay? And you can see the dynamic changes. Looking at the aorta, okay, when you're pumping fluid in, okay? Someone's in pulmonary edema. We'll look and see and we'll play in all that stuff. All right. So what's the purpose of it? Screening tool, okay, assess with treatment, procedures, cardiac evaluations, resuscitations that we talked about from there, shortness of breath, blood pressure, and then OB. Okay. Last year, someone's pregnant, we looked at the baby, fetus, and all that stuff. Head up, head down, are they delivering, not delivering? You can kind of sort of see all that stuff. Is it a ruptured? Did the uterine rupture? Is the baby floating in the abdomen? Okay, you got a low blood pressure and all that stuff, or a hypertensive OB patient. So it has a lot of clinical purposes. 1794, okay, Lazaro, from there looked at back echolocations, okay? Think of bat. That's the only good thing, from my opinion, the bat gives for us, okay? Otherwise, they're rabies-carrying creatures, and I don't care for them. 77, theory of sound, from there, Pierre and Jacques, okay, they discovered the piezoelectric effect, which is the huge factor. Pierre and Jacques Curie, who else? Anyone else know Curie? What? Madame Curie, but what else? Who came up with radiation? Okay, Curie, okay, yeah. The person that discovered nuclear and all that stuff. That's her husband and brother-in-law and all that stuff. So a smart family, I guess. Hydrophone, from there, looking at sonar in the 17, okay, so our Navy ships, that's how we get that. And the first medical application was in 42. 51, looked at what's called the B mode, which is the basic mode, which is what you guys will be playing with the majority of the time and seeing. OBs was the first real clinical that pushed for ultrasound. Why? Looking at the baby, it's not, we don't want to radiate mom and the parasite. Okay, so we need to have some other factor in play and all that. AMA supports it, okay, and then from there, in the 2000 range, okay? And it's now, for an emergency medicine doc, it's a requirement for us. My residents spend months and months, okay, looking at and playing with ultrasound stuff. It is the future, Okay? Top right-hand corner, you see the old stethoscope and then the new stethoscope coming through, but it is, okay? In the back of a helicopter, you can't really hear anything, but you throw an ultrasound on, you can see patients having beat lines, which is an indication for pulmonary edema and all that stuff. You can look at the cardiac. You look at the aorta. Okay, is the IVC and all that stuff collapsing down? Okay, meaning that they don't have enough fluid. So it gives you real-time exposures. All right, so for the next 10 or so slides, okay, yes, okay, have to talk the physics, okay, yes, I'm gonna, like everything else, deep dive in there, all right, it's the necessary evil. All right, so what is sound? Okay, energy that travels, just by the definition, all right, we know that. How does sound travel best? What medium does sound travel best in? Nope. Water. Okay? Because if you hear a boat traveling along and you hear it, okay, you may hear it, but once you go underwater, what happens? It intensifies. Okay? So water is our friend. Okay? Air is not our friend. That's a huge thing when we start going. Water is our friend, meaning gel and all that stuff is our friend. You can never not have not enough. A lot of knots in there, okay? You can never not have enough gel and all that stuff. If you can't get a good picture, throw more on there, okay? And you have to have some form of medium. Ultrasound. Ultrasound is the higher level, okay? Infrasound is 20 hertz. Human hearing, what we hear is 20 hertz to 20,000 kilohertz. From there, ultrasound is after that. Okay? So when you get to the 20,000 to 1 megahertz, and then ultimately from the 1 megahertz and beyond to the 10 megahertz, that's what we use as in the medical field. Okay? So we'll talk about the hertz and understanding all that stuff because it's the frequency side of it. So it's 1 to 10 megahertz is what we're using. Terms, okay? Velocity, amplitude, wavelength, and frequency. We'll take each one of those and go from there. Okay, amplitude is the loudness of it. Okay, if you see the peak and the sides and all that stuff, okay, it is how big the wave, how tall it is. Okay, versus a small one, you can't really hear it, versus a big, loud one. Okay, that's how much energy is coming back to you guys. Okay, and that's the play of it. And it's the intensity. Does it hit and come back when we get the reverberation, which means that you get a whole bunch of whiteness hitting solid objects and come back? It's going to send it forcefully back and have a larger amplitude. And it helps with the brightness side. The wavelength, okay, from crest to crest, this is the definition of the wavelength, is how much time. That's the distance it takes, okay? So now we have speed, distance, and time, okay? And that's how we can kind of sort of come up with our, how the machine calculates things through. But the wavelength is from crest to crest is what is the distance from there. If you can press that down, okay, meaning that you get a whole bunch of wavelengths in one area versus expanding it out, you don't have as many wavelengths. So that does have a factor. And when we play with it is the picture quality. The frequency, okay? This is the number of waves, or the wavelengths, okay, we have per second. So I know I have a distance, I have a time, and I have the number, so the machine can calculate speed and all that stuff. It's all physics. Okay. Again, for us, the audible, what we're hearing, 20 to 20,000 hertz. The diagnostic, 1 to 10,000, megahertz. Okay. So lots and lots and lots of waves in there. Okay. High frequency versus low frequency we'll play with. Okay. High frequency, what do you think of? Okay. How many waves are in there? A lot, okay? So if I have a lot of waves in there, what do you think the picture quality will look like? It'll look better, okay? I'll have a better picture, but the penetration of it, okay, will be worse, meaning that it will not go deep in. So when you have something that's 10 megahertz, okay, you get lots of waves, okay, and this is going to be the ideal thing when we're looking at doing our peripheral IVs, insertions and all that stuff. We'll use a 10 megahertz probe or a 7 megahertz probe, okay. Great picture. We want to be able to see the blood vessels, okay, versus I have a penetrating wound, okay, or I have abdominal trauma. Do I care about what the picture looks like? No, I want to be able to see inside. I had to get deep, okay? So we got some of our corn-fed Pickens County people, okay, that are pushing 500-600 pounds, okay? You can't see inside the admin with the high-frequency probes. So you need a low-frequency probe to be able to see inside. I just got to see, is there blood, not blood? And we'll play with that. This is the key factor, okay? The frequency for you guys is, if anything in physics, this is what you need to know.
Is that something we'll be able to adjust on?
Yeah, so it depends on what machine you're using. The benefit of the Butterfly or a lot of the new handheld POCUS ultrasounds is it's all built into one, okay? Versus the machines that we play with, you have 4 different probes and to play with. And we'll get into all that in a bit. Good question. All right. Size of the length, okay, affects the depth. Low frequency, meaning there's not a lot of waves inside. So low frequency equals deeper penetration. What is the picture quality? Worse, okay? High frequency, see, you guys already got there. Good, POCUS, woo, we're done. Not, okay? So low frequency, okay, increased wavelength, okay, better penetration, less blurry, or it's more blurry, okay? High frequency is better picture, but lower penetration, okay? Those are the key things for you guys, okay? Velocity, okay? This is just the speed of the wave, so we take the wavelength, okay, look at the amplitude, look at our distance over time period, it's 1 second, and then that's how we get the speed of the waves, okay? The machine knows this. The machine knows that tissue is 1,540 meters per second, okay? So it knows, okay, that's a constant, okay? That is the speed of sound going through water. The machine knows this, so then from there it calculates everything else out. Okay, it has the time. It knows that in one time, okay, the period and all that stuff is 1 second. So then it has to figure out on the frequency, okay, this is how it's working backwards. Okay. Once I give the wavelength numbers, I have 1 second, I have the speed, it'll tell, the machine will know how many frequencies, how many waves are going through there at 1 point in a second. Okay? That's the benefit of the machine. We don't have to do it. Okay? But we have to understand the physics. And then from there, hit and come back. Okay. Again, okay, Madame Curie, okay, she discovered atomic energy, okay, nuclear. Okay. The brothers, okay, they discovered the piezo effect. Okay. What they did is they kind of sort of figured out crystals. They put crystals from there. They put a electrical impulse. It charged the crystals, and from there they started vibrating, and then they sent out a signal. They actually looked at thermal. They were looking at thermal temperatures and all that stuff. So they knew that when they used an electrical piece to the crystals, it created something mechanical because it produced heat.
So we almost had kyber crystals, is what you're saying.
Yeah. 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 Okay. And that's where the whole process. All right. We good for physics? Okay, like I said, there's only a few slides, but important to understand. All right. So where do we go from here? Okay. Talking about how do we take the piezoelectric effect, take the crystals, create waveform through electricity, hit the waves, taking all that physics stuff. Ultimately for us is we want to be able to see something. Okay. It's great in thought and theory and all that stuff, but we want to be able to see. All right. So the crystals inside the probes, the old probes actually was a crystal. Okay, not just one crystal, actually hundreds of them. Okay, the probes themselves were about $10,000 to $15,000. This was years ago. Okay, and if you dropped it, okay, what would happen to the crystals? They break. Okay, so they were expensive. I mean, some of these machines are $70,000, $80,000, $90,000. Okay. Nowadays is that we don't have that, okay? They've actually taken technology, okay, and they use the semiconductors, and they put a whole bunch of little semiconductors on the end of the probe. So the butterfly probe has thousands of little semiconductors, and that's what produces the sound waves for us. So still using electricity, but now it's all through computer technology and all that stuff. So that's how we get the ability for one probe to do what we need to do.
And I think that peanuts are stopping us there. What's there? What? The hell is wrong with you? We cannot talk at the same time. I talk, you talk, I talk, you talk. That's it. Focus.
Okay. So yes, okay, talking and listening, okay? The probe does this, okay? Can't talk and listen at the same time, okay? It does it in milliseconds, okay? Sends out the signals, and then it listens back, all through the probe head and all that stuff. So the electrical current hits the crystal bounces, vibrates, because that's how it used to do. Vibrate, sends off the sound wave, okay? Leaves a trail from that stuff, the echoes, so it goes over, hits something, and then it comes back, okay? And it knows how much time it takes over and how much time it comes back. It knows the distance, okay? It has the wavelengths, okay? It has its constant, 1,560 meters per second, so it can actually kind of sort of adjust, and that's how it forms the picture, okay? It is, okay? So just like Hansel and Gretel going over and getting attempted to be eaten by the witch in the gingerbread house and all that stuff, right? So it does leave its trail. Listening, okay? Sends off, hits something, comes back, okay? It knows timing, and then it just kind of starts putting in the piece of, I have this here, it came back quick, so this is white, okay? This took a whole bunch of time to come back, okay? So it's a gray. This never came back, okay? So it's black, okay? But it doesn't come back. So it really from there, that's the kind of sort of how the echoes, the brightnesses and all that stuff. So it sends off, waits, comes back, accepts it, and then inside the computer, it builds its picture for you. Attenuation, okay, is how you can kind of sort of, the sound goes through process, okay? The deeper it goes, okay, the weaker the impulse is, okay? Just like in the aspect of when you shout into a cavern and all that stuff, the echoes, it will come back to you, but over time, it gets less and less and less. Okay. Air, okay? Air is our enemy, okay? Air's our enemy, okay? Sound waves don't like air, or ultrasound waves and all that stuff don't like air, because it keeps going and going, it doesn't come back. Right? Bone, then muscle. Why is muscle better? What does muscle have? Fluid in it, okay? Fat is great, okay? So again, our larger adipose, kids and all that stuff, they're great, okay? When I'm looking at an appendix on a chubby kid versus a thin kid, it's easier to see on a chubby kid, if they have a perfect appendix or their appendicitis, and then play. And of course, fluid is our best. Okay, fluid's our friend, air's our enemy. 42, anybody? What's 42? Exactly. Hitchhiker Guide to the Galaxy. Answer to life. Okay. Ultimate goal is what you guys are kind of sort of is you want to, tissue and all that stuff, what looks like and what looks opposite. That's what you're trying to determine, okay? So this is the only point in time that the liver, okay, the liver actually gets, okay, its glory, okay? Because what they base most everything on is the liver, okay? We can talk about the 50 shades grade and all that stuff, but the liver the term is our iso, okay? That's our isoechoic structure, and then go from there. Okay. Terms, gray, okay, is 50 shades of gray, okay, is a little bit gray, a lot of gray, black versus white, okay, but it's all gray. Is the brightness. The isoechoic, okay, same echogenicity as the surrounding tissue, okay, all of our solid organs and all that stuff. This is the liver, okay, you have gallbladder, fluid, blood vessels, and all that stuff. But you get this spattering of grayness. Okay. And next week you will start seeing and playing when we do that, okay. But this is what everything is based upon is the liver and the grayness. White structures, if we have white, what do you think? How's the sound coming back? Fast, close, okay? Meaning hidden is coming back, so you get this amplitude and it's quick coming back. That's how we get the whites. So we're looking at the diaphragm, our fascia and all that stuff. Bone, okay, that will be looking at as white. Black, again, from the aspect of the terminologies, the anechoic structures, okay? The medium, it keeps going through it, okay? So air, okay, and then some of our fluid-filled structures and all that stuff, because it just keeps going and going and going. So when we look at the gallbladder, when we look at fluid inside the belly and all that stuff, it comes back as anechoic. Okay, ana meaning none, without, coic, sound, okay? So without sound, that's how it gets its names. Hypercoic versus hypoechoic. Hypercoic, bright white, okay? If it's hyper, it's white, hitting, coming back, excited, however you want to think about that, okay? Hypoechoic is the darker, okay? Hypo, low, sound, okay? It's not quite anechoic, okay? Because anechoic is without anything. So if you're looking in here, you have some things that are a little bit darker than others. The white here is the hypercoic, and the black is anechoic. These are the terms, okay? Anechoic is without sound. What color is it? Black. Okay, hypoechoic is darker, okay, hyperechoic is white, okay, isoechoic is gray, okay, and everything again is based upon the liver, okay. That's the only time that the liver gets any benefit, unless you're an alcoholic, and then you go from there, okay. We can kind of sort of look through lines, boundaries, okay, because we use the lines because they are the fascia in that. It gives us our hyperechoic, our white, and that's how we'll delineate things. So when you're looking at the heart, it's encapsulated by the pericardium. You can see that. It gives a nice, when you're looking at the spleen, the kidneys and all that stuff, it's encapsulated. So it'll build, it has some hyperechoic side of it. And that's how it creates the pictures. All right. So this structure in the middle, what is it? Okay, so we presume it's a blood vessel. Why? Okay, so we have something that is fluid filled. So what is the center picture here? What color is it? Black. So that is anechoic. Okay, we have something that circle around this here. Okay, what's this? Hyperechoic. Okay, so we have a hyperechoic surrounding anechoic. Okay, and then from there we have some hypoechoic on the outside. And we'll talk about this here in the future when you start looking at shadowing and all that stuff. Okay, so the probe marker here shooting down. So I have the circular field. Okay, is this a high frequency or a low frequency? High frequency. Okay, why? What? Clean image. You got a good image. Okay, so we know it's a high frequency probe, 8, 10 megahertz. Right? How do we use things? What can happen from the sound waves and all that stuff? Okay, it can be absorbed, it can be reflected. Okay, you can scatter it or you can fract it. So different places and pieces. And we use these, okay? Again, the machine will use it to build the picture. We, at times, use it for seeing things and understanding what's going on. So when I have something that is refracting going through versus a scatter, okay, I know that there's structure that's pushing the sound or pushing the waves and all that stuff off. Absorption, just by the name, okay, the tissue itself holds it. Okay? They just hold the acoustic energy. They don't let it go through. Reflection, hits it, bounces back. Okay? This will be where bone and all that stuff. Okay? Bone reflects, okay? Or it'll hold on to some of it, but predominantly it'll reflect it back. Okay? Sound waves hits it, comes back quicker. Okay, so what color, what traditionally is bone? White. Okay, so that is a hyperechoic. Okay, scattering. Okay, where they hit and they meet irregular media. Okay, you fracture a bone. Okay, you can actually see the fracture lines and all that stuff because when it goes, the sound waves go through, hits, and it scatters down. It pushes elsewhere. So it comes back as irregularities and all that stuff. Stones, okay, gallstones and all that stuff. Kidney stones. Again, it'll scatter through that. In the lungs, when we're playing with A lines and seeing A lines and B lines and all that stuff. For CHF, you get scattering effects. And you can see the B lines, they look like flashlights just swinging as the person breathes. And then ultimately refraction, right? Hits the sound and it refracts off. So the prisms, when you put a prism up the light, how you get the colors and all that stuff, making a rainbow. Resolution is how good we're trying to look at. Okay, you get an axial resolution versus lateral resolution. It's just kind of sort of how the machine is pushing through and seeing the pictures. Axial resolution, do you want it left and right versus a lateral resolution, top, bottom? And to play, does it to kind of sort of make it look, the pictures and all that stuff. And depending on how the beams is going through. Axial images lie in the plane, sound, increase frequency to increase resolution, okay, versus the lateral, perpendicular, adjust focal zone to increase the resolution. The newer technologies and all that stuff, you don't have to worry about that. We'll talk about the TCG or the time constant gain and all that stuff, but you can adjust things. I want to see something a little bit deeper to pull it down so you can play and go from there. All right. So air, okay. Air, what is air? Air is our enemy, okay. You can at times going through, you can see A lines, which on our lung, okay, coming across, you'll see the reverberation, so you get some scattering going on. So it'll hit one spot, hit another spot, then bounces back, and that's how on the lung field and all that stuff. So that's just the reverberations, okay? Bone, you'll get the leading edge. After that, it gets absorbed through. Right? So you won't see behind the bone at times. Fluid is our friend. Okay? We'll play with this for pregnant patients, have a full bladder to be able to look at the baby. The heart, at times you'll actually shoot through the liver because the liver is lots of fluid. Okay? To be able to see the heart and all that stuff. So fluid allows for our propagation, and then partial propagators with tissues and all that stuff. So coming through to the end for this. Piezoelectric. Applied to a crystal. Okay. I don't care if you guys remember about Jacques and Pierre Curie. Don't care. Okay. I just think it's great history from that. Okay. So we have electricity hits a crystal. Crystal then vibrates. Okay. It starts shaking. And what does the shaking do? It produces sounds. Okay. So sounds, and then from there it directs it out in a specific pattern and all that stuff. Okay. So how many wavelengths it has, how many the frequency is, how many the sound pieces that go through from the aspect of the picture qualities. Okay. Coming back, it accepts, so it talks, it waits, it listens. It talks, it listens. It talks, it listens. Right? And it's doing it in milliseconds. And then ultimately, the strength of the electricity and all that stuff allows for our pixels. And we'll talk about the color modes and all that stuff later. All right. Questions on any of that? Okay, so the orientation, okay, you will have some, when you start playing, spatial, I mean, if you're really good at first shooter, active shooter games and all that stuff, it makes it a little bit easier to kind of sort of do this, okay? Because the spatial orientation is different, because everything's flipped. And if you go into cardiac mode, it's even worse because then it's flipped and you're thinking in one way and it's all backwards. Okay, so we have to know where the probe marker is, okay, on all the probes, and you'll see and we'll play, versus compared to where it is on the computer screen or the monitor screen and all that stuff. Okay, and then what's right and left, what's top and bottom, and go from there. Also depends on how you have the probe. And then from there you can get different images, same organ, just based upon your probe markers and all that stuff. All right. So our planes, sagittal versus coronal versus transverse. Okay, from there, sagittal splits left and right. Okay, coronal plane splits front to back, and then the transverse plane splits top and bottom. Okay, so superior versus inferior, right, left, side to side. Okay, caudal versus rostral. Axial, across the planes. Okay, and then from there a little bit separates the transverse separates the superior and the inferior. Okay? So the probe marker, okay, when you're playing with the probes, you'll actually can feel one side that might have a little divot or a little bump. Okay? That's the probe marker on the machine, or on the ultrasound probe. Okay? It will correspond, you'll see there's a little dot on the top of the screen on which side the marker is playing. So from here, if my probe, I'm in a transverse, okay, meaning I'm shooting through, kind of sort of splitting the body, okay, top, bottom, right. The probe marker's on the right, right. So for all the probes, we do the probe markers to the patient's right or the patient's head, okay. So when you're doing ultrasounds, it's either to the patient's right okay? Not your right, okay? The patient's right or the patient's head. That is kind of sort of the standard nomenclature. So if I'm shooting, okay, my probe is going from front of the body to the back, okay? So the probe marker's on the right, okay? Patient's right. So what's closest to the probe is anterior, or what is the most closer, the most proximal to the probe. Okay? So if I'm shooting from the anterior to the posterior, I'm shooting from the front to the back. This is on the patient's right. That's on the patient's right. Therefore, what's on the left-hand side of the screen is the right. So it's opposite for you guys. Yes? Okay. Confusing? It will be for a little bit until you're like, oh no, this is nothing. Okay? Again, it's just knowing and playing. Specifically when we're doing like IV ultrasounds and all that stuff. Some people actually have to flip the probe around to the opposite because when you start sliding the probes. Okay. So what's closest to the probe? Probe marker, probe marker. What's furthest away from the probe? Okay? If the probe marker is facing the patient's right, this will be on the patient's right. Now if I flip this, if I turn this and put the probe marker on the patient's left, okay, this will be the left side of the screen because the probe marker will be over here. Actually, it'll be backwards. If that's over here, but the probe marker's over here, this will be to the left. Okay? You actually flip things around. Okay? But for us, okay, nomenclature, the probe marker goes to the patient's right or the patient's, okay. Sagittal plane, okay, splitting left to right, okay. We're splitting left and right. Probe marker, patient's head, probe, go from there, okay. You can actually have it, different plays and all that stuff, right? Perpendicular ground, splitting left and right. Okay. So to the patient's head, going up, okay. Take the picture and if we spin it, okay, what's closest to the marker is, again, anterior, because I'm still, beam is still shooting through, so I'm shooting through, okay. This is closer to the probe, so this will be what's anterior to me. What's behind is going to be the posterior, but just knowing the location, it's no longer left and right, and my probe marker is going up. This side is going to be my head, and this will be my feet. Yes?
Makes total sense, because 2 days ago I was using a butterfly on a 3rd trimester pregnant woman, and like I had the blue dot facing the head, and like on the screen, the baby's head was on this side of the screen, and his feet were on this.
Yep. So the head was down. Okay. So if we're in the 3rd trimester, where do we want the head? We want the head down. Okay. Because if the head would have been up here and the baby and the mom's contracting, what do we have? Breech. Okay. So yes. So real world application, just by that, going hit. Mom's contracting. Where's baby? Okay. End of play. All right. Coronal, okay. Split, front, okay. Anterior posterior. So we're shooting from the side, okay. We're shooting from the side. So we're going from side to side. And then the probe marker will be always towards the head, okay. If we're shooting from the side, this is our anterior, okay, depending on what side we're on, okay. If we're on the patient's left side shooting across, this is anterior left. So what organs are going to be the closest on this side? What? On our left side? So spleen, stomach, kidney, heart, left lung, okay. Pancreas in the middle, but yeah, play from there, all right. If we do this side, if we shoot here, anteriorly, what's going to be closest? liver, gallbladder, lung, okay? Other kidney, the right kidney, okay? So that's how it is. So we'll have the liver up here, and then the potential at times you can actually see the heart, the gallbladder, and all that stuff, because it's going to be behind the liver. Head, okay, marker. Head is going to be to the top, to the left, okay. Feet will be to the right. We good? Understanding? Coming together? Okay. What's isoechoic? Gray. Iso means same. Okay. So same, echoic, so same sound, so gray. Okay. Hypo is darker. Hypo means less. Okay. Less waves, less sound. Anechoic is black, means without, so no sound. Hyper is white. Hyper is ADHD. Okay. My kid. Okay. Hyperechoic. Okay. So lots of waves. There's times that we do, okay, we will play with oblique views. If you have an adult, how do our ribs go straight across? No. Our ribs are going on a 45-degree angle, okay? So you'll have to be able to get into the rib as you actually will change your probe angle, right? So you go to a 45-degree angle and all that stuff to push through. Different plays, different C's, okay? And we'll go more from that standpoint. All right. How do we kind of sort of play with the probes and all that stuff? All right. The Lumify, the Butterfly versus Sonocytes, Philips, there's a whole bunch, okay? These machines, this is what I learned on way back when, okay? The Sonocyte M turbos and all that stuff. This has different probes, okay? 4 different probes you actually take off and attach to the machine and to go from there. So if I want to put an IV in, okay, I will use a little, the footprint, okay? Or a hockey stick that has, a 10 megahertz, had to take that attachment off and put the other attachment back on. Versus when we play with the butterflies next week, all that you do is you hit a button, okay, and you select what you want, and the machine does it for you. Some of these, the Philips and all that stuff, they're Bluetooth now, okay? So you Bluetooth it through. Uses more battery power, more consumption, and to go from there. And then you have to base everything upon Bluetooth technology. The transducers, okay? Just from the aspect of how do we see, what do we do, which one do we choose is based upon what you're looking for, okay? Fast exams, you're looking at a 5 megahertz, 3 to 5 megahertz, okay, from that standpoint. Again, IVs, putting IV insertion, looking at the eye, okay? If you want to look at the nerve in the back of the eye to see if they have ICP, increased ICP, so if they have brain herniation going on, you can look at the nerve and see the diameter. So you can see increased cerebral pressure with that. Okay? You can see, hey, I can't see on my eye, do they have a retinal detachment? Okay? So high quality, high frequency, okay? Less penetration. So it really depends on what you play. All right. 1 to 5 general, admin, cardiac, lungs. Okay. We won't be doing any transvaginals, so you don't have to worry about that. Okay. The butterfly doesn't do a transvaginal. You need the transvaginal probe or the endocavitary probe, which is along from there. Okay. And then the 5 to 10 is our vascular small parts. Okay. Again, high frequency, we get greater penetration. What's the picture quality? What? Bad, okay? So low frequency, better penetration, picture quality is poor, okay? High frequency, better picture, but lower penetration. All right. This is what they kind of sort of looks like, okay? The footprints, this is what it's called, the probe the probe footprint, okay? A phased array is usually a little square versus a linear, looks like a rectangle box, okay? Versus the curvilinear, okay? It's called a curvilinear because it's linear, like a linear probe, but it is curved. Ah, amazing, right? The endovascular or the intercavitary probe and all that stuff, it's a curvilinear probe, okay? And play from there. Okay. So what the purpose, the majority of the time, are curved probes or curvilinear probes and all that stuff. Convex versus microconvex, depending on the size and all that stuff and playing, okay? Our curvilinear, traditionally, it's our looking at the heart, abdomen, gallbladder. When we do our FAST exams, the curvilinear probe, it's the major one. Right? Majority of the curvilinear probes, high frequency, low frequency. Low frequency because we want more depth, don't care about the picture. Okay? That's what our curves and all that stuff. Okay? And then, of course, the intracavitary probes and all that stuff. Okay. The footprint, okay? From here, it's a curved footprint. So when you're looking at the screen, what is it gonna look like? It's gonna look like a fan, okay? Because the beams are going out in like a fan format. Versus the linear probes, okay? The beams are all going straight, okay? So I take my flashlight and intensify it and I get a beam, okay? Versus I pull it back in, what happens to the beam? It bronzes out. That's how we get the curvilinear, that's how the curvilinear. Versus the linear, I'm focusing I just want to look at one spot. Okay? Our linear probes, what do we traditionally use linear probes for? IVs. So our linear probes, are they going to be a high frequency or low frequency? High frequency because we want good pictures, less penetration, less depth. Okay? When I look at the eyes, I use a linear probe. When I look at the lung for lung sliding, okay, I use a linear probe. Okay? Because I wanted to be able to really see the ants marching. I wanted to see the starry skies of the sandy beach and all that stuff. Okay? And the lungs, I mean, they're only within an inch, traditionally, okay, from that standpoint. So for pneumothorax into play. Sector or the phased arrays, how it was built was they actually took a square, maybe a little bit of a rectangle and all that stuff, but they put different crystals into sections. So one would fire off, and then another one would fire off, and then another one would fire off, and then another one, and they would kind of sort of like your kids are flipping on light switches and all that stuff. Turn this light one off, turn this one off, turn this one off. So it looks at the pieces individually, the sounds and all that stuff. That's how they get the phased array. Traditionally, I love the phased array. This is my kind of sort of go-to. I use it for about everything. Okay, but it was really the heart when they were looking at, because they wanted the aspect of to be able to see a little bit of a curvilinear, okay, because of the scattering and all that stuff, but it's still predominantly straight. So our cardiac, this is our cardiac probes and all that stuff. So what does the butterfly do for us? Okay, the butterfly gives us all into one. Okay, it will take our phase plus our curvilinear and our linear and pulls it all into one probe and based upon semiconductors and all that stuff. Depends on which one you choose. On the probe marker, okay? On the probe you'll have, depending on which company you use, some will have a little indentation, some will have a little dot, okay? And with gloved hands on, okay? Because you always want to put your gloves on, especially patient contact, okay? So you have your glove, you can feel which side, so I know that when I'm playing, the aspect of my screen. So you'll have some form of marker, depending on what the company is, okay? The butterfly uses a little green dot. Sonocyte has a little S, okay? Philips has this little weird signal and all that stuff. So they'll have some form of signal and all that stuff. Probe marker, body marker, or the screen marker. That way you'll know top, bottom, right, left, depending on which one you play. Okay. Abdomen lung vascular, okay. Patient, the probe marker goes to the head or the right. Okay. Saf lad, 12 o'clock, abdomen, okay, 12 or 9, depending on, okay. So if we're shooting through, depending on which way you're playing. If I'm doing a baby, okay, I might have a transverse, okay. So I might be shooting to the mom's right hip, looking at the baby. And then I can spin it to the mom's head it'll give me, then I get a 3D picture. Okay. Bladder, the same thing, okay. Shooting to the mom's right versus the top of the head and all that stuff. Okay. Cardiacs, okay. Probe marker is now on the screen marker is on the patient's, okay, it's on the left-hand side of the screen. Okay. So for some reason, cardiologists, they want to be difficult, so they flip everything around. Okay. Probe marker, depending on where you're holding all that stuff. But so if you're looking at a screen, you do a cardiac screen or cardiac picture. If it's on the left-hand side, you know that this is you're in cardiac window mode and all that stuff. Okay. Again, depending on what you're doing and playing all that stuff. Still, patient's right, patient's head. Okay. Just different plays and lies and all that stuff. How do we hold it? Okay. Pencil hold versus body hold versus hand stabilization. Okay. So sometimes you'll actually grab it on the top and look and play. Sometimes you'll grab it from the bottle, okay, just like you're holding a pencil. That's the pencil hold. Okay. If I want to get deep inside, I grab it on the top and push down. And actually, if I'm doing a heart, to be able to get under the ribs and all that stuff, so to really push it through. Different plays, different pieces, and go from there. Okay. Indicator, okay? This is where our indicator is, our little notch and all that stuff. It's a little bubble, finger, and all that stuff. That's called the leading edge, okay? And if the other side is the receding or the non-indicator edge, God bless. Go from there. All right, you guys want a break? All right, take 5. Good morning. Huh?
And I could just kind of draw it out so you just know what I'm thinking in my brain. So like, we got an arm or something like that. You got vessels right here. You got your bone, and here's your probe. And it's looking down, and the image you're getting, is like, okay, you got a vessel here, your bone, and you got your skin or whatever. So that's like almost like a cross section.
So
right?
that is a transverse plane?
Yeah.
Okay.
Transverse. But then when I was like looking at,
so we're gonna
that
do.
lady's.
So your beam does shooting through. Okay.
Yeah.
Okay.
But then like when I was looking at the baby, it was like I can see like its face and its arms and its legs, and it was like almost like this way instead of, I don't know, it's just kind of flipping it around in my brain.
Yeah. So you're doing a transverse plane on mom, okay, but how is baby laying?
Like upside down.
So baby could be actually.
Oh yeah.
Yeah.
Okay.
So baby could be off. Baby could be off plane.
Okay, so that makes sense because I was sitting it from like this angle. Okay, so that makes sense now. Okay.
Yeah. So if you're shooting here, you're shooting through. Okay. Baby could be laying like this, or baby could be like that. So you could actually be full plane on baby. Okay, so you could be in a sagittal plane.
If I was going from here, I could actually see like that nice picture.
Yeah.
Okay.
Yep.
Gotcha. That makes sense.
Yeah, you're on a transverse plane on mom, but you could be on a sagittal plane on baby.
Gotcha. And then like when we went up top, we could see the gender and everything.
Yeah,
So,
push down and rock it down through.
yeah, we all got together and like before we like met her, they know it's a girl. We're like, hey, look, there's a penis.
I have parents all
But
the
now it makes sense. I'm just like trying to picture. I was like, why did I see it like that? But now it makes sense. So, I got it.
Yeah. So just it's the unfortunate when it comes to like the parasites and have the parasite inside. It depends on because they'll flip. So you'll be doing it and then they'll flip to a different plane. So yeah, exactly. Checking.
Are you starting now?
In a second.
Are you gonna ask me? Oh, I'm curious.
Wait. I'll take it. No, I can't take it.
All right. So questions? Anything so far? Anything? Yep, that's fine. And that's the majority of you guys will be asking. And then hopefully a couple of my partners will be here also. I'm going to try to get some of the residents to come too to play.
So you're going to be here.
Yes.
On our schedule, it says today and Wednesday. You're going to be here Monday and Monday.
Yeah. Yeah. It's next Monday. We're doing not happening Wednesday.
Okay.
Yeah. Next Monday.
You know, we didn't figure out if we have to be here Wednesday.
I would probably say yes because you guys are going to have to review something. Yeah. Yes. Okay. Yes, we're doing this. All right. So as a reminder, YouTube from that. Okay. So pre-hospital physician. If you search that pre-hospital physician on YouTube, this is where it'll be. Okay. Give me a couple days and I'll have it uploaded. And then I'll actually send Tim the link and go from there. All right. Because I'll have to send you the other 2 links, which will be hidden. You can't to see. All right. How do we? Okay. The probes and all that stuff is the nomenclature of how we manipulate the probes. Okay? When I say, hey, rock it, sweep it, slide it, press it, okay, rotate, those are the kind of sort of the pieces and all that stuff. What you're going to be doing with the probe. Okay? Sliding or sweeping, okay, is as the name implies. You're taking the probe and you're sliding the probe, or you're sweeping like you're sweeping a broom. Okay? Just like you're going back and forth. Okay? You might have to slide up a rib, slide down a rib, slide across the heart. Okay? To kind of sort of look at the whole picture. If I'm putting in the IV, I'm going to poke, slide, poke, slide, poke, slide, because you want to be able to maintain the tip of the needle. And we'll play and see. Okay. Tilting, toggling, fanning, okay, they're all the kind of sort of the same terms. I traditionally like more the fanning side of it. And it's just like a fan, okay? You're fanning it, okay, toggle, putting on a toggle switch, light switch, turning it on and off, so you're going back and forth. It depends on the axis. Rotating, okay, am I just gonna spin it around, okay? Versus the rocking, going back and forth, and the compressing. When we're going through the piece, okay, perpendicular to the body, okay, ideally that's what you want the probe marker is perpendicular, so 90 degree down, okay. And then depending on if you're on a sagittal plane, transverse plane, coronal plane, and all that stuff. It has all different factors. When we start, okay, what's happening here? They're bouncing, so this is weak reverberation. Okay, so it's coming down, hitting, and the beams are going off. So how is our picture quality going to be? Weak, blurry. Okay, from that standpoint. Again, the probe, if the body's at an angle or something's, okay, you might have to adjust accordingly your probe to get that to that 90-degree angle. Okay, what we talked about earlier, baby, if you have a baby, okay, you might be at one angle, okay, but the parasite inside's at a different angle, so you have to adjust it to be able to see. Okay, the heart, right, depending on where they are, I have to adjust it to be able to see, because how does the heart sit? It doesn't sit straight up and down. It's here and it's tilted back. Okay, so the atria are actually in the back. Slide, sweeping, all right, motion, all right, either sliding up and down, okay, and you can see the picture, how it's moving, left and right. Slide up and down or slide left and right. Move the entire probe specific directions. Okay, fanning, okay, I like the term fan. You can do tilt, toggle, whatever one you want to from that standpoint. What you're doing is you're tilting, okay, you're on the short axis, okay, the short side, and you're fanning it back and forth on the short axis of the probe. Going back and forth. So am I going to, if I have it here at 90 and I tilt the probe, okay, if it's markers to the patient right and I tilt the probe up, what's going to be on the screen? If anterior posterior here, what's going to happen to the picture? It's going to make it blurry, but what am I going to start seeing more of if I start fanning it with the beam, the lungs, or I'm starting to see things going up towards the head? So when you're shooting down, okay, I'm going from anterior posterior. Now if I fan it, I actually wouldn't go inferior to superior. So I'm actually on the screen. It changes from front to back to now this might be a inferior to superior side of it. So that's kind of sort of your orientation when you're playing. You'll change that. So when you're sitting there thinking like, oh, what am I looking at? Okay? Just the play. Okay. Rotate. Okay. Around an axis, all I'm doing is just spinning it. Okay. I want to go from a transverse to a sagittal. So when I look at my blood vessel, I go from a circle to a line, because I'm now looking cross-sectional on a blood vessel to turn it. Now the blood vessel is going straight up and down. Same thing like with a baby. I wanted to see the head rotate. The heart, I can actually change when we do our different views of the heart and all that stuff. Okay, am I on a long axis versus a short axis versus apical forechamber? And all that I'm doing is I'm just rotating the probe, and it'll give me different axes or different pictures. Rocking, okay? You're on the long axis, okay? You're rocking back and forth like you're in a boat, okay? I want to see this side, nope. I want to see that side, nope. Maybe I want to go back to the right, no, not quite, okay? And I want to get in the middle. So slide, rock, slide, fan, right? Playing with all of that. And then ultimately the compression, okay? Okay, when I'm pushing through, I want to see, is it an artery or is it a vein? Okay? What do veins have? Not a lot of muscle. What do arteries have? Muscle. So can I compress an artery? With enough force, yes. Not as easy because it has a structure. Okay? So when you're sitting there and pulling, okay, you can actually see on this one, okay, it's pulsating. Okay, so you'll see something that's pulsating versus if I compress it down and I think it's a vessel and I push down on it and collapse down, that's probably a vein. Or, okay, if they're tachycardic and hypotensive and you compress down, what are they in? If you have a trauma patient that's tachycardic, hypotensive, they're in shock. What type of shock? Are they compensating? If they're hypotensive or if they're hypotensive and tachycardic, they're decompensated. They're in a distributive or hemorrhagic shock. Okay, so the artery might collapse down. Okay, because there's nothing inside there. What does that patient need? Blood. Okay, so in a matter of seconds, okay, you have a tachycardic hypotensive patient that they're collapsing down. Okay, what stage shock are they in? What's 1, 2, 3, 4? What stage are they? They're in 3, potentially to 4. Okay? So in a matter of seconds, you already know what's going on with them, what they're going to do. Okay? In treatment-wise. Okay? For next week, and for terminal competencies, that's how it's going to happen. Okay? You guys understand? That's the questions I'm going to be asking. All right. Picture screen, okay? Again, pulling all back, okay? We take the probe, okay? What side is the probe on? Marker? Patient, so it's on the screen right. So is this it's a cardiac, okay? So anytime that the marker's on the screen right, that's a cardiac. Everything else will be on the screen left, okay? What footprint are we using? The fan footprint is a curved. So this is a curved or curvilinear. So this is a curved probe. It looks like a fan. Okay, it's curved. If it was a linear, the footprint would be straight. And of course, the phase array is also a box. Okay, so if I use a curved probe, okay, what's the megahertz for this? Is it a low frequency or a high frequency? Low frequency. So if what? 1 to 5. 1 to 5 for my low frequency. Okay. Good job. Okay, you're getting there. All right. High frequency is 5 to 10. Okay. So the high frequency linear probes. Curved is low frequency, so 1 to 5. So my penetration is deep. My picture quality is poor. Okay, yes? Good, isn't it? Just by looking at a picture, you guys already have a lot of information. All right. Beam mode, brightness mode, this is kind of sort of the basic mode, okay? Everything's in a 2D picture and all that stuff, okay? We'll play with motion mode some and then Doppler mode, just let you guys go. But we usually, for the majority of times, the M mode or the Doppler mode, we don't do a lot in the POCUS side, or in the pre-hospital. All right. You can throw the patient in M mode and look like barcode scanning. When you're looking at the baby, like to get fetal heart, okay, you can actually throw them in M mode because it's a motion mode. As their heart's beating, you can calculate it out and all that stuff. And then Doppler, what is Doppler? It gives just the weather forecast and go from there. Okay. So when we're looking at color, predominantly what's coming to you versus what's going away. Okay. It's blue and red. It's not blood. It's not venous. It's not arterial. It's what's coming to the probe and what's going away from the probe. Okay. So if you have depending on which way you have the probe fanning, you can actually change the color, Dopplers and all that stuff. Okay. 2B B mode. Okay. All right. So our picture. Okay. What side is the probe on with marker? Left side. So this is this the cardiac? No. Okay. What's the footprint?
It's not.
It's a curvilinear. Okay, good. So it's a fan out. So we're getting into a curvilinear. Okay. So our frequency, low frequency. So our depth penetration is deep. Our picture quality is poor. Okay. From there, we're shooting through, okay, this structure here, okay. This is supposed to be our isochoic structure, and our predominantly isochoic structure that we want is the liver, okay, and then playing from that standpoint, okay. Different shades of gray, okay, 50 shades of gray and all that stuff with a little bit of white and black. Brightness mode, okay, echo, 256 grades, shades of gray, okay, from different places and pieces and all that stuff. Okay. M mode or motion mode, okay, as the name implies, it's motion. It looks at, okay, heart-to-heartbeat variability. You can actually look at blood flow. You can see as blood, because blood will cause turbulence as it's going through the veins, so you can see the motion. Cardiac activity, you can see that, fetal activity, and all that stuff. Okay? Different pieces in place. Okay? Curvilinear, probe marker, but then from there it takes a cross section and it looks at just that piece of the cross section. So wherever your line is on the probe, and you can actually manipulate that too. Okay? Versus the Doppler shift, okay, returning sounds, okay. As a color flow Doppler, we're looking at the weather, okay, sweeps through, it looks at, gives you nice pretty pictures and all that stuff, okay. A different accent of our ultrasound using the Doppler mode and all that. Again, color-wise, okay, this does not mean it's arterial, that does not mean it's venous. Red means it's coming to the probe, okay? Blue means it's going away, okay? So if I have the probe in a perpendicular and I angle it cephalad towards the head or on the arm going superior, what blood flows is going to the probe? Arterial, okay? Because arterial blood is going in, venous blood is going away. Now if I rotate it and I fan it towards the hand, okay, what blood is coming to the probe? Venous. What blood is going away? Okay, understand? So it really depends on how you have your probe lines and all that stuff. Color flow, of course, blood flow, tissue motion, velocity, and we talked about all that stuff. Okay. Image artifacts. So earlier I talked about the aspect of utilizing scattering and reverberations and all that stuff. So there's times that we want to actually use artifacts for a reason, okay? Or what it gives us information on the picture, okay? So knowing that something's going to scatter, something's going to refract, it's going to be absorbed and all that stuff. Okay. If I'm doing a aortic ultrasound, okay, my first object that I'm looking for is the spinal column. Okay. What's on the outside surface of the spinal column? Bone. Okay, so what is that going to, what color is that going to be? White, which is hyperechoic. Okay, so I'm looking for a hyperechoic structure, and behind it is going to be black because it's going to absorb other sound. It's going to reverberate the top part of it, okay? And it's going to absorb the rest of it. So I know inside, so I have this white on the bottom of the screen, I have this white structure, and then behind it, it's going to be blackish, okay? Once I know my spinal column is on the aorta, I'm looking for two little, okay, anechoic structures that are circular, that rounded right above it. Okay. One's the aorta, one's the IVC. Okay. On the screen, my marker is going to be on the right. Okay. It'll be on the screen right. Okay. My probe marker will be on the patient's right. Okay. So what sits on the patient's right? Blood vessel wise, the major blood vessels inside the body. Inferior vena cava. So the inferior vena cava sits on the patient's right, aorta sits on the patient's left. So on my screen, okay, my screen, because it's flipped, patient's right, patient's left. So on the left hand or the right hand side of the screen, which is patient's left, is what my aorta is going to be. Versus on the left hand side or the screen left, patient's right is my IVC. Understand?
But what you're describing, I'm looking at you on the screen.
Correct.
Just got
Reversed.
but
Yeah.
That's your right is on the left. So it's just looking at like on the screen.
Yes.
Right?
Exactly.
Okay.
So a lot of times what I do is I'll put my screen, instead of looking and have my screen at the feet, I'll put the screen at the patient's head, and then I put the marker, my probe right, everything is matching the screen. Different plays, different pieces, okay? So again, that goes back to the piece of the puzzle is I'm using all of these pieces, okay? So I'm using reverberation and scattering to see a hypercoic, okay? So I'm making my outline for the spine, knowing that behind it is going to be absorb the rest of the sound waves, so I know where that piece. Once I have my spine, okay, then I start looking for other pieces that I want to. My blood vessels. So if I have something that's huge, okay, on the right-hand side of the screen that's greater than 3 centimeters and it's pulsating, okay, what do I have? I have an aortic aneurysm, okay? If it's 10 centimeters, okay, and they're hypotensive, and I see a little bit of anechoic around it, what do I have? Dissection, ruptured, okay? Am I gonna sit and play? No, okay? Am I gonna take them to a Coney Memorial? No. Yes, take them to Canada, okay? If you want them to die, all right? So from that standpoint, you can actually change the outcome. If I have that, they're going to someone that has thoracic surgery. Okay? Your choice. I don't care. All right. Acoustic shadowing. All right? From the aspect here, structure dense, bone, okay, air, soft tissue, solid objects, stops waves, reverberates the waves, sends the waves around. Okay? Solid objects, stops the waves. Gallstones, okay? Bone and all that stuff. All right. So this structure, okay, first of all, what is our probe? What's our footprint? Curvilinear, okay. If I have a curvilinear probe, what is my frequency? Traditionally low. What's our penetration? What's our picture quality? Poor, okay. Can't see the top of the screen, but the marker is going to be there, okay. So from there, okay, my probe marker is here, okay. If I'm shooting, okay, if I'm doing a transversal eye, right, what's up here? Anterior, this is, right, this is right, left, okay? If I rotated it, okay, so I'm going into a sagittal plane, okay? If I'm going up, down, okay, so markers now to the patient's head, this is anterior, this is, and this is. Good job, okay? You guys are getting it. Okay. 50 Shades of Gray, okay? Do you guys see all the different colors grays? 256 colors of gray, okay? Again, getting into knowing structures, okay? This is my isocoic, okay? That's the color that you're kind of sort of looking for. I have an encapsulated structure. I have white. What is white? Hypercoic. So my hypercoic structures are bone, fascia, tendon, diaphragm, thick fibrous tissue. I have then something that is, what color is this? That's anechoic. Anechoic means black without, So I have something that's anechoic. What's our anechoic stuff? Fluid, lung, air, because it just keeps on going. That is surrounded by that's encapsulated next to something that's isochoic. So this is our gallbladder. Okay, if I'm in the right upper quadrant, okay, shooting through that, okay, that's what I look for. Okay, that's a gallstone. Okay, so I have something that is hyperchoic on the top, okay, less on the backside. So it's absorbing, it's reverberating because my beam is coming from the top, hitting this, which that's hyperchoic, so it's sending back quickly, and behind it can't see. Okay, so behind it though, can beams go through? So you have no beams going behind the rock. Okay, so this is called an acoustic shadowing. So I'm using the beam waves. I have something that is hard inside the gallbladder. If they have right upper quadrant pain, hard, okay, this is a gallstone. Okay? Done. Okay? If they're symptomatic, something like that, simple for me, I don't need a lot of testing. I call the surgeon. I got a symptomatic cholelithiasis. Okay, I'll be down to see the patient in a minute, take them to the operating room. 5 minutes, bam, done. Disposition, out the door. Okay, go from there. Brightening area, okay, simple cysts, fluids, okay. From that standpoint is we actually use certain things to enhance other things. Okay. So what's our friend? Fluid's our friend. So fluid will enhance. We need lots of fluid. So if I have the bladder, I can actually see behind it. Okay, this is actually the gallbladder from there. So you'll have, if this is the bladder kind of, so you can see behind it better because there's fluid, so the waves travel through it faster and it enhances the picture. It gives me a clearer picture because it's going to hit that area and then come back, right? Because it's not stopping it. For this one's gallbladder, kind of sort of seeing behind the gallbladder and all that stuff. Edge artifacts, okay? Using reverberation and scattering. Those terms that were before. Hits, so if the beam is coming down, it hits, bounces off, so it will actually enhance depending on, okay, like if this is a baby, the position of the baby, or for this one, the gallbladder is actually positioned off. So I'm shooting down, if the gallbladder is positioned left, right, at an oblique angle, it'll give me a different picture. Okay? Wall thickness and going from there. Beams between reflects, okay? Scones, pleura, skin tissue, and all that stuff. Okay? Frequently, we'll use this on our lungs. Okay? Gas bubbles. You'll see reverberations going back because it's actually hitting the gallbladder and it's bouncing back. Foreign bodies, when you're actually, foreign body going from there, okay? The bowels, when we start playing through, you can see the air bouncing, it gets inside the tissue and it bounces back and forth inside the tissue. So you'll see bowels. When we look at our lungs and all that stuff, all the A lines. Comet tails, okay? You actually come down a little bit. So it pushes through into this isochoic structure. Sorry, hypoechoic structure, anechoic structure. Let's try this again. Anechoic structure. Okay? So you actually will get some reverberations coming through. The lungs, when we start doing on the FAST exam and all that stuff, you'll see the comet tails coming down. Okay? That's an indication for fluid inside all that stuff to play. Mirror artifact. Okay? So I have, what's this? So I have a hyperechoic structure, okay, that's surrounding the liver, okay, because this is our liver, okay, which is isochoic. Gallbladder is anechoic, okay. This is the diaphragm, okay. That's what our diaphragm looks like, okay. So it's hyperechoic. So the machine, okay, the machine doesn't know at times. So what it's doing is it's shooting through, okay, hitting that. I have this gray, this white shoots through, hits something struck, and then it's behind it, it's a void. Okay? So what's in the void? What? Pleural space, which is air. Okay? So you're actually in the lung, so it loses its being, it loses its sound. Nothing's coming back. So the machine is like going, what does it do? Oh, well, crap, I don't know what to do. Okay? So what it does is it actually creates a mirror. It'll take all this stuff and just flips it over. Okay? That way I know when I'm playing and I'm looking that this is air. This is what the lung looks like. Because you actually will see a mirror of the gallbladder and liver and all that stuff. If I have a patient that is satting 70%, they got crackles, rhonchi, okay? And I throw this on, the probe on, I see my liver, I see here. If I don't see the pseudo or the mirror artifact and I see anechoic here, what do I have? Fluid, so I have pulmonary edema. Right? So if I lose that mirror artifact, because I know I should have a mirror artifact. If I don't have that, and I see all black, that is pleural pulmonary edema. CHF, 4+ pitting edema, satting 70%. What do they need? CPAP, nitro. Okay, transport, go from there. Okay. Understand? Good? Yeah. All right. And, okay. So the butterfly, okay. Originally come from that standpoint. From there, we use play, pieces, and all that stuff, okay. So a quick, just kind of sort of the knobologies, okay. The gain versus the depth, when you're actually looking at this, and you can play with this. When you touch the iPad, you can actually drag it down or left and right from that standpoint, okay? So you can change the depth, okay? How far you want to go down versus I want to see something closer up, just depending on your play and all that stuff. Left and right is the TCG or the gain, right? The time gain constant and all that stuff. It's the penetration, how much energy, okay, do I want to go through? If I can't see, I'm really fuzzy, I'm hypoechoic here, but I need a little bit better picture, I can change the gain in this area. Just like you're on the old television sets, twist the knob and all that stuff, and you can, a better picture here, better picture there, and all that stuff. Right? So you can do the same thing. The good thing is with the butterflies, the majority of the time is once you do the preset, it will adjust everything for you. So you usually don't have to do much adjustings. Okay? So high gain, low gain, high gain, okay, better. Low gain, high gain, a lot of gain. Okay? So just what you're doing in the adjusting side of it. Okay? So what do we want? This is the picture that we want. So you can change the gain for here and change the gain for here to get this versus, adjusting backwards. Okay? Because can you see the kidney here? Okay? No. Partially see it here. See the kidney here, liver there. Okay? And this is all whited out. So different plays and all that stuff. Post-processing, okay, compensated absorptions from there, okay, near field versus far field, depending on what you want. I want to see structures that are far down. I might change my gain to have a better down here. I don't care about the gain up here because I want to see structures down here. Right? This would be like if I'm doing the aorta. I don't care if there's something on the outside. I might got a 500-pound person. I don't care how much fat I have here. I need to see down here. Okay. versus if I'm looking at the eye, I want to look at the nerve of the eye. I want better picture up top. Adjusting from there. Depth. Okay. How deep are we going down? Okay. Do I need to have my depth set at 5 centimeters if I'm going to put it in a peripheral IV? Why? Way too deep. Okay. So what's our traditional depth of a peripheral IV? Less than 1 inch. An inch is 2.54 centimeters. So I don't need something that's that deep. Okay. Likewise, if I'm looking at lung sliding, okay, is the lung on the outside or the inside? It's more on the outside. Okay. So I don't need a lot of depth to look at lung sliding. Okay. 3 centimeters, 4 max. Now, if I'm looking at fluid and I want to see bead lines, I need to have a lot of depth because I need to see the bead line going all the way down. Okay? So there's numbers and all that stuff to play with. So it really depends. Okay. Presets. Okay? When you turn it on, okay, this is kind of sort of what your screen will look like. Okay? What footprint am I using? Curve. Okay, I'm using a curve linear. Okay, marker is on the right-hand side. Okay, so am I in cardiac mode? No, I'm not in cardiac mode. Okay, so low frequency, high penetration. So most likely I'm going to be shooting something like gallbladder, abdomen, aorta, something like that. Okay. I can change my time gain. I can switch pictures, depth. Okay. If I hit the preset, I can actually choose a whole bunch of different presets. Okay. Fast, which we'll talk about in a bit, musculoskeletal, cardiac, deep, bladder, OB. Okay. All that's just by clicking some buttons. Okay. The actions. Okay. If you go in there, you want to play with it, there's some education videos on there, okay? Sonosite has a good website. Go on YouTube and you can just look at videos on ultrasounds and all that stuff, okay? What they do. From there, we're taught, okay, label things, especially in the future if you're going to be billing, okay? So you have to have CQI process, right? Making a marker, putting the labels on and all that stuff. This is the gallbladder. This is the superior aorta, inferior aorta. I'm on a peristernal long axis, peristernal short axis. Okay. Oops. Okay. Okay. And then a fast, right upper quadrant, and again, you can just choose buttons. Okay. I want color, I want mode, I want to go M mode. From there, I can choose just quick buttons and all that stuff. Okay. Freezing. Okay. Okay. Looks like a little snowflake. Okay. So it'll turn white versus blue and all that stuff. That will change for you. So choose, okay. What does the name implies? Freezes the screen. Okay. Why do I want to do that? Okay. And then also, what else? Sometimes what I want to do? If I want to measure it. Okay. If I want to get the volume of a bladder, I freeze the screen, I do my calculations from there, and then switch it, and I can actually get my 3D picture. So I can calculate volumes. Okay? I want to, how big is my aorta? Okay? From there. If I'm doing sniff tests and all that stuff for IVC, collapsing, I can measure that. Of course, unfreeze, flips colors. Okay. Review images. Okay. You freeze or unfreeze, take it back. If you take a picture from there, you can go back and look at the clips from there. Okay. If it's frozen, you can take a picture of it, just as the camera shows. Okay. From there, you can do measurements. So if I freeze it, take a picture, then I can, do all my labeling and measurements. Different place. And the last, okay, looks like a little recorder, okay, cinematography and all that stuff, okay. It'll take a picture or a time period. Usually it's a 6-second clip, okay. Some are 10s, some are 15s, okay. depending on which. The butterfly actually doesn't stop, okay? So if you hit that button, I mean, you can go for a minute, minute and a half, 2 minutes, and you can just look and see. So a lot of times we'll do this is take a sonography, especially if you're doing CQI going, I don't know what that is, snap the camera, and then you can rock, toggle, play through, and get the whole picture of what's going on. All right. If you're putting in an IV, hit the button, and then you can actually march it and watch the IV going through so you can go. Okay. We'll play with this for intubations wise. You can see the endotracheal tube inside the trachea. Good qualities, okay, adequate penetration, structures, fluids, okay, internal echoics, correct orientation, labeling, marking, and all that stuff, and then our sizes and shapes. Okay.